Hello, I'm Dr. Raquel Bennett from KRIA Institute, and today I'm going to be talking about different ways of conceptualizing ketamine treatment for mental health indications. So let me start by telling you a little bit about myself. I'm a psychologist and a ketamine specialist located in Berkeley, California. I've been studying the therapeutic properties of ketamine for 20 years, since 2002, and I work now in collaboration with medical professionals. I am the founder of KRIA Institute and KRIA Conference, both of which are devoted to the uses of ketamine in psychiatry and psychotherapy. I have no disclosures of any kind, nor any conflicts of interest to report. Today, I'd like to talk about specifically about racemic or generic ketamine and how it's used for mental health indications. As I said, I'm planning to talk about different approaches to ketamine treatment, specifically a biological approach, a psychotherapeutic one, and then a psychedelic approach. So the purpose of this talk is to enhance communication between different parties, specifically between providers and their patients, and also clinicians who are looking at the scientific literature. It's important to understand the paradigm that the provider or author is operating from in order to better understand fundamentally what they're trying to say. So here I'm trying to give more language to different paradigms for treatment. So let me start by saying that in every ketamine treatment, I always conceptualize it in 4 steps. So the first step is patient selection, which is also part of treatment planning, but first determining whether an individual is a good fit for ketamine treatment and whether it's likely to be helpful and it's clinically indicated. So that's the first step. And the second step is patient preparation. As you know, ketamine is different from other kinds of medications and pharmaceuticals that are currently available. And I believe that it requires specialized psychological preparation before commencing ketamine administration. Then, after those things are done, then you would move to a medicine session. That's the third step, to be followed by some sort of psychological follow-up care. In other words, to make the most use of the material that emerged in the medicine session. So from my perspective, those are the 4 essential steps in ketamine treatment. Next, let's talk about the different variables in ketamine treatment. When I say variables, I mean that there are 5 things that the provider can adjust or control in order to better meet the needs of an individual patient. So those 5 things are, first of all, the route of administration. In other words, how are you choosing to get the ketamine into the patient's body? There's a lot of different options for that, keeping in mind that each route is associated with a different amount of bioavailability. Number 1. Number 2 is the dose. How much ketamine are you administering at any given time or in a single session, and why? Number 3 is the frequency of the ketamine sessions. How often are you doing this? That's related, actually, it has an inverse relationship to dose. The 4th variable in treatment is the setting, specifically the physical setting in which the treatment occurs. I found that this variable is often overlooked in medicalized treatment, but it's actually a really important one when working with a visionary medicine such as ketamine that induces an altered state of consciousness. So I think that merits more attention. And finally, the 5th variable here is clinical presence. That means as a provider or as a clinician, how do you understand your job? Or how do you understand your role in this treatment? And what is it exactly that you think that you're supposed to be doing while ketamine is being administered? Are you focused on medical monitoring? And are you focused on the patient's physical safety? Or are you providing concurrent and synchronous psychotherapy? Is someone in the room functioning as a psychedelic guide and trying to be unintrusive and radiating a warm presence. Some people believe in that. And are you doing a blend of all three? That's fairly common, but just keeping in mind that there's different ways of being with a patient who is receiving ketamine. All right, let me dive in. I want to talk first about a biological approach to working with ketamine in clinical practice. Sometimes called the biochemical approach or a pharmaceutical approach, sometimes referred to as the research protocol, because so much of the early research was done using this strategy. This strategy usually refers to giving 0.5 milligrams per kilogram of body weight of ketamine, usually on a 40-minute infusion. And you probably know that a single session often is not robust enough to give significant improvement to a patient with severe depression. And so our colleague, Dr. McShane, actually pioneered something called the Diamond and McShane protocol, which is to give 6 infusions in a fairly short period of time. So 6 infusions given in a 2 or 3 week period. The idea here is to make a cumulative series to get the total amount of ketamine into the patient's body that would be helpful and robust for a patient, but without giving too much ketamine in any individual session. Here, there's a bias against psychedelic experience. And here, when patients report non-ordinary states of consciousness, those are often labeled in the literature as psychotomimetic, meaning mimicking psychosis. However, I believe that this is a fundamental misunderstanding of psychedelic experience. It's not the same as psychotic experience, and it's unfortunate that these things have been conflated and confused. But in any case, this strategy, a key feature of this strategy is to avoid psychotomimetic experience or psychedelic experience by dosing a little under the profound psychedelic properties of ketamine. So often clinicians who practice in this way are very focused on the medical monitoring of the patient and the patient's medical safety. That's important. I don't think that's the only thing there is to do in the room, but anyway, this is fundamentally a medical or a surgical model in which the patient is conceptualized as a vessel to receive the medicine or a passive recipient of the services. And when you ask clinicians who practice in this way about ketamine as a healing agent, they often want to talk with you about what's happening at the level of biology or physiology, perhaps what's happening at the cellular level, in other words, at the level of receptors and neurons, or potentially activated brain regions. And that's certainly part of what's happening here. Again, I don't think that's the whole story. But it's important to recognize that in this model, psychotherapy is neither recommended nor required. So psychotherapy is not considered very important in this way of thinking about ketamine treatment. And the psychedelic properties of ketamine are considered a problematic side effect to be avoided, essentially. Not embraced, but avoided. So this is by design a sub-psychedelic strategy, as I said, designed to dose under the prominent psychedelic properties of ketamine. So this certainly has its place, and it's ideal for patients who are medically complicated or patients who have a lot of physical pain. But the limitations here is that the effects of this treatment, when you conceptualize it in this way, the effect of ketamine on mood or other psychiatric disorders, the effect tends to be temporary and wears off in days or weeks. And it also, as I mentioned, renders the patient or forces the patient into a passive recipient, a passive position. And while this is a perfectly okay approach, for surgery or for other kinds of medications, I'm not sure that it's the most helpful approach for people who are having a chronic mental health issue. And so I want to talk about some of the other possibilities. I think it's worth noting that the S-ketamine products that are on the market have borrowed from this paradigm and have followed very closely from the original research paradigm. So it's the same conceptualization of the medicine as a pharmaceutical agent. And there's certainly a lot of evidence to support working in this way. You surely know that prior to 2017, 90% or more of the published studies and research that was going on followed this protocol. And it's also endorsed by the consensus statement that was published in JAMA 2017, and also in the international expert opinion that was published in 2021. And there are now obviously thousands of articles in the research literature about this, up from about 24 when I wrote my first book in 2014. So really an explosion of interest in this topic and in this work. So I want to compare and contrast that, what I just described, with a different approach to working with ketamine. So the next approach that I want to talk about is the psychotherapeutic approach. In other words, using ketamine as a lubricant for the psychotherapy process, or a catalyst for psychotherapy. So this has much in common with what MAPS is doing to look at MDMA as a treatment for PTSD, where the medicine is embedded in a psychotherapeutic context. You can do something similar with ketamine. And so here, this is most often done, at least in the States or where I am, using injectable ketamine or with custom compounded lozenges. And here's the thing, you do it less frequently. You might do it once a week or once a month. You don't need to do it as frequently. In fact, having time in between the sessions is important for patients to integrate the material that came up and to prepare for a future session. So spacing it out is actually preferred. And here the idea is to help patients either to talk about material that's difficult to get to otherwise, or to revisit and review material that they've shared already in psychotherapy, and to help them consolidate their insight. In other words, to make it stick or make it feel more solid and meaningful. So this is fundamentally a psychological or relational way of thinking about ketamine treatment, where the emphasis is on the psychotherapy dialogue and the therapeutic relationship and the verbal exchange. So this is quite different from the biological model that I mentioned a moment ago. Here, the psychotherapy is central and essential to this process and this way of thinking about it. It's still sub-psychedelic. You would want to dose under the full psychedelic and dissociative properties so that the patient can be meaningfully engaged in psychotherapy and has the capacity to reflect and to articulate their thoughts. So still sub-psychedelic. This is ideal for patients who benefit from psychological work and who feel ready for that. In other words, patients who can make use of psychotherapy. But the limitation here is that this way of working is expensive and time consuming. And so that's a challenge that we have to grapple with. And I just want to make it really clear that when I'm talking about psychotherapeutic work with ketamine, one thing that's really important is the quality of the therapeutic relationship between the therapist and the client. So it's not just having someone with a psychotherapy or psychiatry background in the room. That's not enough, but rather there has to be a relationship there that's characterized by mutual care and trust and a depth of relationship. It's important for the therapist to have a good sense of the client's internal landscape before commencing this kind of work. So what I really mean is ketamine treatment embedded in the context of preferably long-term or depth-oriented psychotherapy. It's a completely different beast when when clients come and want ketamine treatment with a therapist in the room, but the therapist and the client don't share a substantial relationship. So I want to make that distinction, ketamine and long-term therapy versus short-term therapy. And I predict that as we study this phenomenon further, that we will find a difference in the clinical outcomes. In any case, let me keep going. From my perspective, one of the key advantages of doing ketamine facilitated psychotherapy is to make use of the neuroplastic window that opens up when ketamine is administered. It would appear that certain kinds of learning are enhanced in a window of time, probably 2 to 3 days, beginning with ketamine administration, and then for a couple of days while there's an underlying physiological process that's occurring that results in synaptogenesis. In other words, the dendritic tips are sprouting and forming new neural connections. It seems like the neuroscience is pointing in this direction, that this particular physiological process is correlated with what we can observe clinically. So eager to hear more about that. What I want to say about this is that, from my perspective, the goal of treatment is to help the patient learn new skills so that they can enjoy their lives and be as comfortable as possible without necessarily being reliant on medication forever. And certainly some patients do need psychiatric medication forever, and they absolutely should have that. But a lot of people are frankly over-medicated, and by helping them gain new social and emotional regulation skills and making use of this neuroplastic window, I think that's actually in the best interest of a lot of our patients. So some evidence for this, I think the best place to look actually is the MDMA studies for PTSD, as I mentioned, being conducted by MAPS. Also, Wilkinson looked at this in 2017. That there's the Dorr paper, 2019. I really like the Williams paper. I think the first author on that was Halstead. That was 2021. Dr. Matai just put out a new paper on this just recently, so 2022. So I think there's I think there's a growing body of evidence about this working in this way. Okay, next I want to talk about using ketamine to invite or induce mystical and psychedelic experience on purpose. So working with ketamine in a psychedelic paradigm. So in this approach, in this way of thinking, rather than avoiding ketamine's prominent psychedelic properties, instead of dosing under it, here you are valuing ketamine as a psychedelic and dissociative agent and inviting visions on purpose. Because as a clinician, you think that the visions may be potentially beneficial to the patient, and you think that the patient is appropriate to this style of work. Not every patient is. But anyway, in this way of working, patients typically receive between 1.0 and 1.5 milligrams per kilogram of bioavailable ketamine, often done by injection. And they need time in between the sessions to integrate this or to work with this material. So some patients need this quarterly, a small fraction of patients need this monthly, but you wouldn't want to do it more frequently than that. I think that's too much. So here, when you provide this kind of experience to patients, they are experiencing full dissociation, they're partially immobilized, and they're having colorful dreamlike visions during the ketamine administration, which lasts an hour or two. And so this is fundamentally a shamanic or psychedelic paradigm, as I said, where the visions are valued. and where the visions are conceptualized as part of the healing action of the treatment. So psychotherapy is also really important in this paradigm. The therapy occurs before and following psychedelic ketamine administration, but not during. The patients are generally too dissociated to engage in meaningful dialogue. So it's important to be clear about that. So the therapy is important, but it's, as I said, before and after. And here, the psychedelic properties of ketamine are valued and understood to be essential. So this is ideal, I think, for patients who express an interest in psychedelic exploration and people who have previous experience in exploring their minds through meditation or otherwise. The limitation here is that this would not be safe or appropriate, psychologically safe or appropriate for many clients, so they have to be selected carefully. And so that's the main consideration to think about. They also need quite a bit of psychological support. I also want to point out that I think that in psychedelic treatment, it's essential to identify an actionable step or steps, meaning I think that there's a message in the medicine when ketamine is administered in the psychedelic range that gives the patient instructions on something that they can do on their own in their everyday life, something that they can implement, not when they're medicated, but in their everyday life to help move themselves toward wellness or to maintain their wellness. And so the psychotherapy is often focused on identifying and implementing this actionable step. Anyway, support for this comes from, I mean, or rather, I think a good place to look actually is to look at the psilocybin studies that were conducted largely at NYU, published in 2016. There was a really good follow-up study that was published in 2020. Also look to Krupitsky. He has a wonderful review article published in 1997. Dr. Kulp wrote about this, published in 2007. There's the Luckenbau paper that looks at this in 2014. There was an important paper by Dr. Bennett, published in 2019. I think the first author was Ross on that. By the way, I have all of these papers collected for you on the CREA website. I have a curated reading list there. It's free and it's for your ease. So please feel free to take a look at that. Anyway, there's a really fascinating phenomenon here that I think has been overlooked, and that is the duration of beneficial effect. So we know that if you conceptualize ketamine from a biochemical perspective, that the effect is short-lived, a couple of days, or perhaps from a single ketamine exposure, you may get a few weeks, maybe a few months from a cumulative ketamine series. But more and more, we're beginning to get reports from patients who report months, and in some cases years, and in some cases decades of benefit following ketamine-facilitated psychotherapy or psychedelic ketamine journeys. In other words, ketamine in the psychedelic range. And so I think there's a question there that needs to be rigorously researched and investigated and quantified. So those studies haven't been done yet, but I do think there's something there after receiving hundreds and potentially thousands of reports along these lines. Patients sometimes report that their ketamine experience was some of the most informative and most impactful experiences of their entire lives. And this phenomenon, as I said, has not been well documented. So I think we need to open our minds to that possibility and begin to see if we can understand what's going on there. So in other words, we need to shift our way of thinking away from conceptualizing treatment as symptom management and consider the possibility that there may be something beneficial to transformative experience. And how can these psychedelic agents, such as ketamine, contribute to that? Anyway, let me recap what I've said. First, I talked about ketamine as a pharmaceutical or biological intervention. And then I talked about ketamine facilitated psychotherapy, or a psychotherapeutic approach where the emphasis is on the psychotherapy dialogue and relationship. Next, I talked about working with ketamine in the psychedelic range, where the emphasis is on the visions that are induced by psychedelic and dissociative experience. And so the question is, which of these works the best? And the answer is that different things work well for different people. From my perspective, the skillful ketamine provider is knowledgeable about the spectrum of ketamine services, which includes different routes of administration and different dosing strategies, and is able to match the treatment to the patient depending on the patient's needs. So as far as I know, I've been doing this a long time. There isn't one thing that works well for everyone, but as I said, different strategies seem helpful for different people at different times. So that's where I'm hoping the field is going to go. I have a couple of thoughts here in closing. I don't actually conceptualize ketamine as an antidepressant exactly. It's often talked about in that way, but that's not how I think about it. I think about ketamine as a medication or an experience that enhances resilience. And what I mean by that is that the situations that patients are in doesn't actually change from the time they walk in the door for ketamine treatment and the time that they leave. But what does appear to change is their willingness or their readiness to engage with their challenges and difficulties and to employ coping strategies. And that's the key thing, is how do we help patients to have more and better coping strategies? How can we help them to learn that? They can learn that from mentors or from books or from classes or from psychotherapy. But again, enhancing those coping skills, I think, is critical to optimal outcomes. And I'm also concerned about creating an army of addicts by providing a powerful experience like this, but without psychological support. I think that's problematic, and I think we need to talk about that. So those are my thoughts. There's no doubt that ketamine does something important on a biochemical level, but rather I think there's more to this treatment than just that alone. I also want to emphasize the fact that in my practice, the patients who get well with ketamine treatment and who stay well over time are actually doing a variety of other things and getting integrative treatment and not just ketamine alone. So ketamine is, in my mind, is and should be an adjunctive treatment for depression. So some of the other things that we recommend and that we help patients to implement might include, obviously, individual psychotherapy or group psychotherapy. They may take conventional oral medication. We often look at sleep schedule. Patients often need to exercise more. We often take a close look at their diet or what they're putting into their bodies. Patients often benefit from learning meditation, or rather learning the skills to observe their own minds and cultivating curiosity about that. Looking at having some sort of work or volunteer work or something outside of themselves in that way, and balancing that with recreation time and social time as much as possible, spending time in nature, etc. And then adding ketamine adjunctively to that program. That's where we really get the best results. So something to think about. Anyway, I wanted to add that ketamine is an unusual tool that requires the clinician to have specialized skills and additional training. I have some trainings listed on my website. I'm not training this year, but these are programs that I think highly of. So you're welcome to take a look at that. but I encourage clinicians to pursue further training for themselves. I also wanted to point out that I authored an important document called Ethical Guidelines for Ketamine Clinicians. This is a very short document that was published in the Journal of Psychedelic Psychiatry in December 2020. So you can find this document on that website. You can also find it on my website at CREA. And this very short document outlines the role of the medical provider, the psychotherapist, and the patient in ketamine treatments. It's worth noting that this document has been cited in multiple inquiries to state boards in the US and also in multiple medical malpractice cases. So important to be aware of this document. Please have a quick look at that. And so I think I'll leave it there. You can find further free resources on my website. The reading list that I've mentioned and other resources for providers, scales and forms and supply lists, things like that. You can also contact me through my website. And finally, I'm hoping to do a live Q&A session during the conference. So please check with the conference organizers or the online program for the date and time for that. Thank you so much for listening to this talk.